Well, what we're starting with today is a quick recap of today by two very nice guests from Berlin that joined us here during the last few days. And it's Yasmina and Victor, and they will recap Rush. Thank you very much and have fun with them.
So, thank you and good morning. I'm pretty much impressed that so many of you managed to come this morning despite the late evening you might have had yesterday. Well, as we said, we are Victor and Yasmina from Berlin, and we would very much like to go again with you through the RUSH protocol we already heard about yesterday. So let's start with a little imaginary case. You are a doctor on the ICU and the nurse is calling in the night because one patient is not feeling well. If you look at him, you see that he's rapidly and shallowly breathing, his skin is cold and wet, he seems obtunded. And well, you look for his vital signs and you see that his heart rate is about 140. The blood pressure is pretty low with only 80 to 50, and he's also having some temperature. So if you look at this patient, you would say you have clinical signs of what? Of a shock, correct. So, but now you think, okay, he had some temperature, well, it could be a septic shock maybe. But you also remember that this patient was first admitted because he had heart failure, so you think, well, it might also be cardiogenic. But you also know that this patient has a history of intestinal bleeding. So might it be hypovolemic? Well, it's a big question. It's relevant to you because I think that none of you guys would manage a cardiogenic shock in the same way he would do with a septic patient, for example. So, well, one of your very first question is my patient having enough volume? Because, well, if no, then you should obviously give him volume. But, well, if yes, then you should ask yourself further, why can't he use this volume to supply his organs with oxygen? So we heard yesterday that thanks to ultrasound, we have a very nice protocol we could use to maybe try to answer these questions. And as you might remember, it was the RUSH protocol, the rapid ultrasound for shock and hypotension. And we heard, thanks to our two great speakers yesterday, that it's all about the pump, the tank, and the pipes. We will do basically the same, but we are using a different acronym called HIMAP, which was published in a paper in 2009. It is the same. It is just another way to remember, but it is the same views you are going to look for. Well, HIMAP, because obviously you want to elevate the mean arterial pressure of your patient. Remember, he's experiencing hypotension. So every first letter of this acronym stands for one organ or region you want to look for. Well, first of all, let's say that if once you're going to be a very experienced radiologist or emergency doctor, you might be able to perform this exam in less than 2 minutes. So that's pretty fast, and you could have a lot of information thanks to this exam. Well, we will go through each view. I will tell you something about it, and then Victor will show it to you on the screen, so you could have a very nice view on it. Well, let's start with our first letter, H. H stands obviously for heart, so the pump. And you have 3 big questions you could maybe answer with RUSH. Well, first of all, you want to know, is there a pericardial effusion? Because if yes, then you might have an obstructive shock, and if you puncture your effusion, your patient might go better. Then you can look, how is my left ventricle pumping? And you can also look for signs of a right heart failure, such as right heart enlargement, for example. And you have basically 4 views you could obtain for it. So the parasternal long and short axis, the apical 4-chamber view, and a subxiphoid view. So, well, let's start with the first view. It is which view? Parasternal long axis, very good. Well, you can obtain this view by imagining a line between the right shoulder of your patient and the left superior iliac spine, and your probe should point toward the right shoulder of your patient. And then you obtain this very nice view. So in the last day, we already trained a little bit to identify what you can see. But if we go from close to the probe with the right ventricle, under it with the left ventricle, here the left ventricular outflow tract with the aortic valve, and here you see your left atrium. So in this view, you could look, for example, for a pericardial effusion. And for that, it is very important to locate and identify under your left atrium the descending aorta, which is here this round, quite black structure. It is important because you want to make the difference between a pericardial effusion and a pleural effusion. So everything going in front of this round structure with this descending aorta would be a pericardial effusion. But if the black fluid is going behind the descending aorta, then it will be a pleural effusion. So always identify in this view the descending aorta. You really need it. You can also evaluate how big is your right ventricle compared to the left ventricular outflow tract and your left atrium. Well, when you obtain this view, you should rotate your probe 90 degrees clockwise to obtain the short axis. So now the probe is pointing towards the left shoulder of your patient, obviously. And you can see here very nicely round-shaped the left ventricle and in between the mitral valve, and here around you see the right heart. So here you can, for example, look for the contractibility of your left ventricle. It should thicken uniformly towards the center of your ventricle during systole. Then you should angulate your probe to obtain different cross-section of your heart so you can evaluate it at different levels. And here in the middle, in the center of the image, you obtain your Mercedes star, and that is what? It's the aortic valve. Very good. Well, when you looked for this view, you should slide your probe caudally to reach the 4th to 5th intercostal space in the mid-clavicular line, and you will obtain which view? Basically, you are on the apex of your heart, and you see 4 chambers, so it's going to be the apical 4-chamber view, right? Well, it's a little bit too bright that we can really identify it very well, but you see here on the right side of the screen the left heart. You see here the left ventricle, here the left atrium, and here the right ventricle and the right atrium. You can also see the valves, and well, remember to identify which heart is right or left. You can also look for the tricuspid valve. It should go out from the septum a little bit higher than the mitral valve. So that's also one thing you can always look for, because you might be, I don't know, somehow not well orientated with your probe. So always look for the tricuspid valve and the mitral valve. Well, here you can compare how big is my right heart compared to the left one. it should not exceed 2/3 of the left heart, otherwise you have to suspect a right heart enlargement. And what is a very common cause of right heart enlargement? Pulmonary embolism, for example, right? Well, the last view you could do to look for your heart is the subxiphoid view. So you just place your probe under the xiphoid, and we heard about it yesterday. You really have to angulate it to send the ultrasound wave under the sternum. So here again, you see left heart, so left ventricle, left atrium, right ventricle, and right atrium. So we are now going on with our second letter, so I for inferior vena cava. And, well, the inferior vena cava should be located in a sagittal view under the xiphoid, and, well, basically sliding or angulating your probe 1 to 2 centimeters to the right side of your patient. And, well, you will look for the diameter of your vena cava, and you will look how is my vena cava responding to the respiration of my patient. And, well, the big thing is that you want to know, is my patient having enough volume, or could I maybe give him some volume and help him? Well, you can say that if your vena cava is under 1.5 centimeters and you observe a complete inspiratory collapse, then your patient is maybe lacking volume, and then you should obviously give him volume. On the other hand, if your vena cava has over 2.5 centimeters and you see no or very poor inspiratory collapse, then your patient is very unlikely to be volume responder. You should, suspect maybe fluid overload or right heart failure. And what did we just say? Right heart failure is often due to what? To pulmonary embolism, yes, very good. So if you suspect a pulmonary embolism, then look for deep venous thrombosis by compressing with your probe the popliteal and femoral vein. We're not going to show you that because obviously our ultrasound model is very healthy, so we don't see any sign of right heart failure. But remember, it's very easy to do, and you could maybe see the thrombosis. So we are now going to show you that. Well, here you see your vena cava as it is entering the right heart. And you see that as our patient is inhaling and exhaling, you see the movement. So when he's inhaling, this vena cava is collapsing, and if you would measure it, I think it would be in between 1.5 and 2.5 centimeters. So here you see the liver, just that you can orientate yourself, and here one hepatic vein going into the vena cava. So when you looked for that and decided if maybe your patient needs some volume or not, you can go further. And you look for the M. So our M stands for Morrison pouch, collar pouch, and bladder. And you all know that there are 3 views which are obtained in another emergency ultrasound exam, which is fast. We also talked about the last days. So you have 4 or 3 views, because we did already the subxiphoid view when we looked for the heart, so you don't have to do it again at this point of the exam. But you look for the right upper quadrant, where you look for, do I have some free fluid which will look black in my Morrison's pouch? Do we have a pleural effusion on the right side? And can I see some obvious liver injuries? Then you move on to the left upper quadrant, where you can evaluate your collar pouch. You can see if you have a pleural effusion on the left side. And you can see obvious Mills injuries such as a hematoma, for example, or a laceration. And finally, you move on to the suprapubic area, where you look for the Douglas rump or the rectovesical pouch if you have a man. So let's look for it, and we will start with the right upper quadrant. So remember, you have here the liver. More caudally, you have the right kidney. And while you look here, this is what? The space between liver and kidney? Morrison pouch, very good. And then you look above the diaphragm, which is this hyperechogenic structure. You look, do I have black fluid on the other side? And fortunately, we don't have any black fluid here, so no pleural effusion on the right side. And our liver also looks pretty healthy. So let's continue with the left upper quadrant. It's always a bit more difficult to find the left upper quadrant because, I mean, their organs are more under the ribs. But still, here we have a very nice view of the spleen, of the left kidney, and in between we have our collar pouch. And, well, we don't see any free fluid here. We don't see any pleural effusion above the diaphragm, and we don't see any obvious spleen injuries. So when you did that, you move on to the suprapubic area, and we will look here because we have a man for the rectovesical pouch. And again, we don't see any black fluid. We see here the bladder, which is pretty much filled, but we don't see any free fluid under it. So then you move on. And you have your A from HIMAP. So A stands for aorta. And the big thing you want to figure out or to rule out is, do I have a ruptured aneurysm, which could maybe be the cause of a hypovolemic shock? And, well, the aorta should be examined in a transverse view, and you should place your probe under the xiphoid and then slide it towards the umbilicus. So you have seen the whole abdominal aorta. And you can additionally look for it on a suprasternal view, where you expect to see the ascending aorta, the aortic arch, and part of the descending aorta. And, well, remember that if you have an aortic diameter above 5 centimeters and you have clinical signs of a shock, then you have to assume that your patient has a ruptured aneurysm until it's proven otherwise. You also expect maybe to see a false lumen if you have an aneurysm or a mural thrombus, for example. Well, so let's have a look at, that's first the suprasternal view. So you see here very nicely the ascending aorta, the aortic arch, and here the descending aorta. When then you move on and look for the abdominal part of your aorta, you look for the diameter and you slide, well, you expect here to see the spine and above it the aorta here. So always adapt the depth of your image. You want to see the structure as big as possible. And here you see very nicely round-shaped the aorta. And what was that? You just had one, and now it's two. So it's the bifurcation, obviously, which you would expect at the level of the umbilicus. So again, we have a normal aorta. And we move on, please. And our last letter is P for pneumothorax. Do I have one, yes or not? So we also already trained this view while we were doing the E-fast. And remember, you take a parasternal transverse view, and you should have 2 ribs on your view. And, well, this view is called, don't ask me why, the bad sign, because if you have a lot of imagination, you could see here a bat, which are the 2 ribs and in between the pleura. It's just called like that. I don't know why, but it's like that. So we know that if between our 2 ribs here and here, you see a pleura sliding, then you don't have any pneumothorax. That is due because obviously your parietal pleura and your visceral pleura are one against each other and sliding while your patient is inhaling or exhaling. So you see this movement, and if you put an M mode on, remember we see the seashore or the barcode sign, and which one is the bad one? Barcode, very well, because then your 2 pleuras are not one against each other anymore, but you have the air in between, so you won't see any movement. So let's have a look for it. And you see here our bad sign. That's one rib, that's the other one. And you see in between the pleura here. And you see that it's moving one against each other. So no pneumothorax there. And if you put, well, you look for the other side, sure. And if you then put an M mode on, you also see that we have which sign? Seashore sign. And you see one additional thing. If you look here, you always have somehow some vertical lines. And well, that's the pulse wave which is spreading through the arteries of your lungs. And you can also see them, and you only see them if you don't have any pneumothorax. So if you really want to be sure, you could do some more views on the thorax and look, well, do I maybe have a pneumothorax on any other place of my thorax? But we will just do that. So I think we are almost done with our rash exam. So I would very much like to thank the organizer for have us this speak here. We would like to thank Jens for being our ultrasound model. And finally, I want to thank you for your attention. And yes, keep calm and ultrasound on. So thank you.
Well, thank you so much. I think it was a brilliant recap, like summing up fast in 20 minutes. And it's a bold move to do it with live ultrasound, with 60 people watching in the room, with quite a few people watching somewhere else, and you have to find those views. So, Victor, that was quite impressive, and you nailed it, all of them.
Thank you.
Yasmina and Victor are from the Arbeitsgemeinschaft